Clinical Lead for Access with the Healthy London Partnership. This is the fifth and final of the webinars to launch the London Access Guide and Manual. And today we're going to be looking at key ingredients for access improvements. So really looking at some of the QI methodology and some of the metrics that can help us deliver change in our practices. So today we're going to have an overview of change methodology. We're going to look at how to choose an access improvement project that's right for your practice. We're going to be looking at tests, tasks and PDSAs and measures to support change. If we could go on to the next slide, please. A little bit of housekeeping while we move on to the next slide. We are recording the session today and it will be on the Healthy London Partnership website along with the previous webinars in this series. And I'm sure somebody, David or Adair in the background, will kindly put the link into the chat for us so you can look at those previous webinars if you would like to. So before we get going on today's session, I would like you to go onto menti.com on your phone. So if you just go onto your phone and search up menti.com and add in the code, which we'll also put in the chat as well, so you can come back to it later if you want to. And what we're asking you to do is just think about some words or phrases that would describe success in an access improvement in your practice. So thinking about if you went back to your practice after the webinar today, decided on access improvement project and work through that with your team, what would success look like? And think of some of the words that might mean for you, for your team or for your patients. And if you could go to menti.com and put that in, we'll come up with a word cloud as the session goes on today. So if we could go on to the next slide, please. And I've also been asked to do a plug for some further webinars which are coming from the Healthy London Partnership team and the National Access Improvement Programme, which is 3 webinars which are linked together as a kind of module to look at demand and capacity. And those are coming up in November. And there is a link to this again if you go onto the Healthy London Partnership website, and I think a link is going into the chat for this series of webinars. So if we could move on to the next slide, please. So this looks at the London General Practice Access Guide and Manual, which describe a whole system approach to access. So we produced the guide and manual. The guide is a kind of shorter version to use with the whole team to kind of look at where your practice wants to focus. And the manual is a little bit longer with more detail for those people wanting to lead on the access improvement programs. But what we realized is that access is really hard. We know it's really hard. It's really difficult to achieve. There's not a one size fits all, and we're all in a slightly different place depending on our team, our patients and our practice sort of makeup. So what we've tried to do with the guide and manual is pull together all the right sort of information, best practice, research, resources, and pull it into one place to try and do some of the heavy lifting for practices so you don't have to start from scratch. And we kind of describe jigsaw pieces that need to come together to give a good access offer for your patients. The guide and manual would develop very collaboratively with GPs with an interest in access. We have London-wide LMCs involved, RCGP, the Equip team, and Tom's going to be speaking to us from there later. We had patient engagement through Healthwatch and the Practice Managers Association as well. So it was a very collaborative document, so hopefully that's reflected in the guide and manual. If you are interested, this is the final webinar, but the earlier webinars, as I said, are on the website. The first one looked at general practice activity, so how to match your demand and capacity, but particularly your demand, capacity and need. The hot topic at the moment is how to get the best possible balance between face-to-face and remote consultations, how to manage DNAs, and what are your points of access. So that's covered in the first webinar. The second webinar really looks at an equitable access system and working with patients to deliver that, how to kind of support self-care, how to reach out to your patients who are the most vulnerable, how to work with your patients who present very frequently. The third webinar looked at the general practice team, the sort of foundation of everything we do in general practice, looking at recruitment and retention, looking at new roles coming in through the ARRS scheme, and really looking about how to lead and develop a kind of an effective and happy general practice team to deliver the best possible access offer you can within your resources. Last week, we looked at access beyond the practice, recognising that general practice sits within the wider health and social care system, and how patients access another part of the system impacts on us, and how we deliver our services impacts on other parts of the service. And it included presentations from 111 and how they connect with general practice, and from the new community consultation, the community pharmacy consultation service, which data is demonstrating is reducing demand in practices by up to 10% as patients are diverted to a community pharmacy offer. So today we're talking about making change. And so how can you actually make those changes in your practice to deliver some of the things that we talk about through the rest of the guide? So if we could move on to the next slide, please. So what I'm hoping that everyone will take away from today is a kind of idea of what good quality improvement looks like and what the key ingredients for improvement are for your practice, and kind of whet your appetite a little bit to look further, either in the guide and manual, or even go on to sort of further resources which are signposted from both documents. If we could go on to the next slide, please. So this is a definition of quality improvement from the Health Foundation, which I've included because it describes general practice, QI in general practice. And I'm going to read this because I think it's really helpful. But QI involves a structured approach to tackling complex problems. It offers practices the chance to free up capacity and time by tackling constraints, delays, duplication, and other problems in their care processes and pathways. And it allows them to take a step back and look with fresh eyes at the service they provide and the tools they need to do things differently. If we could move on to the next slide, please. Now, many of you will have seen this slide, and what I'm really hoping that people take away today is kind of an encouragement to just stop and have a think, to take the square wheels off this very heavy burden that we are all carrying in general practice, particularly at the moment, and just to think, have we got the time and have we got the capacity to put some round wheels on the cart? So from that side, if we could move on to the next slide, please. And I'd like now to introduce Anna Burhaus. Anna is an expert in quality improvement, and Anna and I have worked really closely together in South East London on some quality improvement work, and she really opened my eyes to doing things differently, to the importance of stopping and reflecting on what we do, and really having a kind of systematic approach to making change, which absolutely delivered for us and the project we were delivering in South East London. And I'm really delighted that Anna is here today to talk about making change. So Anna, I'll hand over to you.
Thank you, Sian. Thanks for that lovely introduction. And hello, everybody. My name is Anna Burhaus. I come from Northumbria Healthcare. And I'm a clinician by background, and I've been helping to put quality improvement into practice since the early 2000s. So I hope today we're just going to give you a bit of a flavour about kind of why think about quality improvement, and maybe why you might want to start to experiment with putting it into practice if you haven't done already. So we can have the next slide, please, Adair. So at the start of any kind of improvement work that I ever do, I go back time and time again to thinking about, well, before I start to think about improvement, let's think about, what does quality mean for us in healthcare? And although this is old, it comes from the Institute of Medicine from the States, I find it really helpful to think about the kind of the 6 domains of quality in healthcare. So is what we're offering safe? Is it effective? Is it person-centered? Is it timely? Is it efficient? And is it equitable? And why I think this is a really useful kind of resource to keep coming back to is because sometimes with something as complex as improving access, we might try and make an improvement in one domain of quality. And if we're not careful, we might inadvertently reduce the quality in another area. And what quality improvement helps you to do is to really think about how you kind of measure improvement around quality in the round. So can I have the next slide, please, Adair? Thank you. And if you take those kind of 6 domains of quality in healthcare, I find that they can lead you into some really kind of important questions that keep you really grounded in your change methodology. So, will what matters to me be taken into account? Have we got the kind of the person-centered view at the heart of what we're doing? Is co-production embedded in our change methodology? Are we thinking about how to keep safety at the current levels, if not improve it? how do we make sure that care is effective and equitable so that people are getting the right care at the right time? And what can we do to improve the speed or the rate at which we're doing things? And how can we make sure that we're delivering the right levels of kind of treatments and interventions, not too much or not too little? So how do we also think about waste? Next slide, please. So what we hope the guide and the manual will do is to help you in your GP practice think about how you achieve this quadruple aim of quality improvement. So with quality improvement, we're always trying to do 4 things and trying to do them really consistently. We're trying to improve the health of our population as a whole, whether it's in our own patch or at a regional or national level. We're trying to improve health outcomes and make sure that we get a better experience for patients and carers. But we're also trying to improve staff experience too, to make sure that what we're doing maybe reduces stress and increases kind of joy at work for those of us that are in healthcare, because we know that issues like burnout are so critically important, especially at the moment. And also, we're not necessarily always trying to lower the cost of care, but we're trying to, kind of make sure that the cost of care is a factor in our calculations and that we're applying a really kind of robust approach to what we spend our money on and how we spend our money on it. Thank you. Next slide, please. So the guide gives you lots of kind of practical ideas about how to improve patient flow and access. And it's really based on the fact that it's unrealistic to imagine that every single GP practice will be able to implement every change in exactly the same way. Local adaptation is frequently required in order to make the change happen in primary care. And that's because even if you've got a practice within a mile of each other in London, you could be serving different populations, you could be set up in different ways. So the guide not only has kind of some of the best ideas about how to improve access, but the quality improvement methodologies and the change methodologies that are in it are absolutely designed to help you take a big kind of strategic idea and think about how you put it into practice in your local kind of concept. So it's very much based on how do you do this at your grassroots level and not making an assumption that any 2 practices would do this in exactly the same way, because your contexts are very different. So next slide, please. So people often get a bit confused about, well, what's the difference between a structured quality improvement change methodology and just what we do most of us in healthcare every single day, which is trying to improve quality. And I guess for me, there is a really clear difference, which was before I learned about how to do quality improvement as a clinician, I would use what I would call informed intuition. I would look at the evidence base, I would talk with my colleagues, we would have a hunch about what might work and we would go for it. But what quality improvement helps me to do now is to really kind of apply a very structured methodology. It helps me to test things and to review them and to review the evidence that I'm gathering and creating as we go in order that I would know whether a change really is an improvement. And so it takes it from something that feels a bit like informed intuition, and it turns it into something where you can really kind of robustly kind of test whether a change idea has worked in your system. That's really helpful. It's helpful to debate things. It's helpful to measure things really robustly so that you can also decide when maybe a change idea has failed and it hasn't worked the way that you want it to work, and you can then make a rapid adaptation and change. So that's the reason why you might want to use an overarching change methodology. And we're just going to share a few more slides now to kind of maybe help you think that through a little bit more. Next slide, please. So this is a really kind of helpful kind of definition from the King's Fund about what the difference is. And it comes from a really good report on quality improvement from the King's Fund, which we can share in a link with you in a minute. Thanks. Next slide, please. And I think it's also just worth pausing and thinking too about how quality improvement might fit in with other activities that you're doing around quality in general practice. So you will spend a lot of time thinking about planning for quality. You will have kind of quality control mechanisms in place, like how you deal with medicines or prescriptions, for instance. You'll have quality assurance mechanisms in place for audits. And what quality improvement is really, really useful for is when either you want to introduce something new, or you know from your quality control or your quality assurance that you've got a bit of a problem and you need to do something with it, or where the issue that you're trying to tackle is so big and vast and hairy and difficult to deal with that you know that you're going to need a team approach to try and improve it. So quality improvement fits in and can be used really specifically to help you lead change. And we'll help you in a minute later in the seminar to think about when you might do a test of change or whether you just get on and do it. Next slide, please. So I often get asked about with quality improvement, there's so many kind of brands out there and different methods. It all kind of feels really kind of confusing. So I would say that my main message to you is that most of these tools and quality improvement methods come from the same historical roots, and many of them have the same kind of tools in place. And we have included the most important ones of those in the guide for you. So I would say try and keep it simple, and just maybe if you're starting this from new, don't get too worried about all the different kind of jargon and all the different kind of methods and models. Just concentrate on having a go for your first improvement approach using some of the simple tools. And these include, if we can have the next slide, please. Things that are at the heart of every single quality improvement approach. So they're like helping all your team members to understand that you're trying to improve the system that you're in, that you're going to use data to try and reduce unwarranted variation, that you want to create an improvement culture where everybody feels involved, and you're going to do this through creating small-scale tests and trials as a way of learning together as a team. And what you're going to do is keep the needs of the people that you serve at the heart of your improvement focus, and keep coming back to that kind of co-production with people with lived experience to check that the improvements are making a difference on outcomes. You're going to focus on flow, and you're going to keep your shared purpose in mind. Next slide, please. So if you look in the manual, you'll see that we've got a really kind of clear way in which you might approach the overarching kind of change methodology, starting with thinking about the people, thinking about your culture, deciding what you're going to change and why, creating a joint plan together and co-producing that, understanding which measures for quality improvement you're going to use, and then importantly, even quite early on, thinking about how you're going to sustain and spread any changes that you make. Next slide, please. One of the main kind of quality improvement tools that you'll find in most improvement methodologies is called the Plan, Do, Study, Act cycle. And the manual helps you to understand how you can use this very, very simple tool that you can really learn just in a few minutes, and use that as a team to put really rapid tests into place, so you get very instant feedback about how you're doing. And those small scale tests of change help to grow your confidence as a team and help to give you kind of feedback about whether you're on the right track with your improvement approach and your change methodology. Next slide, please. What you're really trying to do is, rather than introduce a change idea or that comes from on top and feels a little bit imposed on you as a team, you're trying to take, you know, kind of ideas, and often in healthcare that's based from evidence about what we think works in most healthcare. But what you're really trying to do is to test that at a local area and work out what works for you, and then get going with implementation as quickly as possible. Next slide, please. The other important thing to say about quality improvement is there are a lot of technical tools and methods that you can learn, but actually the mindset around quality improvement and the team culture that you build around it and the factors that are to do with people in your team are really, really critically important too. So you're also trying to create this culture which is very inclusive, where everybody has a voice and where the people closest to the work are the ones that are leading the change. And making that process as democratic and open as you possibly can. Next slide, please. So in summary, we just want to say that the guide and the manual will help you to kind of think about how you might use and choose your change methodology. It is, I'll be honest, it is some effort to get it into practice at the beginning until it becomes almost like a habit, like the way that you do things around there. Once you've made that investment as a team, I don't think you'll look back because it's so helpful and you can use it for multiple projects, not just for access. It's very collaborative. It's based on you working well as a team, and actually just using the tools and the methods can help you to improve your kind of culture in the organization too, because they're based on that kind of sense of everybody having shared ownership of the work that you're trying to do. And these small improvements that you can make can actually lead quite quickly to some big changes. And one of the things that you can notice is if you can start with some of the kind of low-hanging fruit around this, you can actually create some time for yourself to start to tackle some of the bigger issues. So quick, small successes can be really, really helpful. So we hope that some proportionate use of the QI methods and tools will really help you to improve your outcomes. And I'm going to stop now and hand over to the members of the team to take it forward, and happy to answer any questions later.
Thank you, Anna. That was really great. It really sort of, all of it sort of resonated with me. And I think you're quite right. It does take time and effort. There's no easy or quick fixes to this. And we do hope the Access Guide Manual recognises that we all start in a different place and we all have different needs. And you need to find the bit of it. You're not supposed to read the whole thing from start to end, but that you find the bit that's important for you. I forgot to say at the beginning, please do all use the chat, thoughts, questions, frustrations, disagreements, anything you think that you'd like to challenge, please put it in the chat. We're also asking you to answer a question in the chat about what it would feel like for your team or for you or for your patients if you had a successful access project in your practice. If I could ask David to put the question in again for the Menti, and if you go to menti.com and the code is in the chat. So please do put your words and thoughts in there so we can capture some of that during the session. If we could move on to the next slide, please. So we're going to talk just for a couple of slides now about what to change and why, where to start, where to make that decision about what access improvement to start with. And I think Anna's given some really good ideas there. If we could move on to the next slide, please. So in the guide, we talk about, as Anna mentioned, this 20-80 split. So there's this thing called the Pareto principle that states that 20% of the sources cause 80% of the problem. So how do we find that 20% that really matters and focus our efforts there rather than on things which are likely to have less impact? So when you're thinking about starting an improvement project, there's some questions that you may want to ask yourself within your team about, so if we do this, who are we looking to benefit for? Who's the benefit for, and what kind of benefit are we looking for? How are we really going to engage the team and service users in that improvement work so it feels like a real team effort? And then coming back to the PDSA, is this something which is a QI project or an implementation project? And Tom, I think, is going to touch on this a little bit later about the difference between a task and a test. And then these three bottom points were really about thinking what's within our control to change. Lots of things aren't, so let's not waste our effort there. But think, is this within our power to change? Look at the things that we can't change and sort of throw those away, and really think about what's within our power to change as a team. So what are the skills within our team that we can really make the most of for this improvement project? If we could go on to the next slide, please. So in the manual and the guide, we've got lots of ideas of places to go for improvement ideas. You might want to think about patient safety, cost effectiveness, the joy of the team at work, making sure you've got your team input into this. And also there's external requests that we always have coming down to do this and that and the other. And so how do you kind of get this in balance for the right thing for your team? We signpost to the NHS 10 high impact actions to release time for care, and there's a lot of resources around this if you go to the link in the guide or just Google that into the NHS resource. Tom's going to talk in a minute about using patient experience and feedback to measure change, but this is also a really good source for improvement projects. And then if you want to go a little bit deeper, you can go to the Institute of Health Improvement Change Concepts, which looks at about eliminating waste. I'm really sorry, I'm having internet problems. I've moved about 3 rooms. I hope I'm back with you now. If we could move on to the next slide, please. So just a final slide about just some tips for thinking about improvement ideas, and do this as a team so everybody's engaged. Think about what you don't want to do. Think about the things that you're currently doing that you don't need to do anymore. So have a to-don't list, things that you want to stop doing. I like this idea of don't innovate but exnovate. Remove older technology and things that you're doing to make space for new ideas. Find out the pebbles in people's shoes, the guru wall we call it. So get everyone to a room and put post-it notes on the wall saying, what would you really like to change? And that could be from your patients, from your team, from your partners. Find out what people would like to change. And then please do use the guide and manual. We have included a list of suggested improvement projects. There's a short list in the guide and a longer list in the manual in the appendix at the back. And we suggest small steps or larger steps, suggested QI methodology and suggested data that may help, really to kind of get you going and to kind of whet your appetite for an improvement project that might work for your team. I'm now going to we could move on to the next slide. And what I'd like to do is introduce Tom Margam, who is a colleague of mine from East London. Tom is part of the EQUIP programme, which has done a huge amount of work in East London practices using data and QI methodology to improve things generally. Tom was a big part of the task and finish group of the guide and manual, and you can kind of feel a sort of Tom thread through both documents. And Tom's going to talk about tasks, tests, PDSAs, and then measures. So I'll hand over to you, Tom, before my internet goes again. Thank you.
Thanks, Sean, and thanks for having me today. So I thought I would sort of try and sort of bring some of the theory into life for folks around sort of around PDSAs and testing, because I think it's one of these things that I think when I first started doing quality improvement, it looked very, very straightforward, and then what I realised over sort of bitter experience is that actually you've got to unlearn quite a lot of ways of behaving to really get into this sort of testing, prototyping mentality. And I think one of the things when we're talking with teams about improvement work is trying to avoid kind of wasting time on stuff that just needs to be done, and then keep your testing for the stuff that requires where you've got a bit of a hypothesis or a hunch and you want to try something out. So one of the things we ask people when they're doing some improvement work is when they're thinking about some change ideas, is it just something that just needs doing? Like, is there evidence for a change? The risk is you can approach every issue around access like it sort of in a sort of artisanal way, like it's only your practice or your team that have faced this challenge before. But there's loads of good evidence out there about things that have been tried and tested that just work. So when we talk to teams around their improvement work, it's really important just to think: is the thing we're doing a test? i.e. we don't know what the answer is, we've got a hypothesis or a hunch about what's going to happen, or is it just a task we just need to do something? So we've got some examples here about a really interesting one might be about an Accurex reminder for patients to have a blood pressure check. I mean, that's just a thing that you need to do. The language you might use, or the time at which you send that out, or the different cohorts that you send it out to is the thing that you might be testing. Just as in, if you're trying to improve your stuff, the quality of stuff or practice meetings, ground rules can be really helpful, but that's just something you've got to do. Testing whether they make a difference to how people feel about the effectiveness of the meeting, that's the actual test. Can you go on to the next slide, please? And I think the big trick for me around testing is understanding the scale at which you test stuff. A lot of the time when we see people sort of writing down what their next plan, do, study, act cycle is, when I look at it, it feels like almost like an entire project plan on a page. And I think as GPs, and certainly from looking at lots of appointment systems over the years of working with teams, you can see the evidence there of lots of implementation of stuff and probably not quite so much testing. So what was maybe thought to be a test is essentially implemented without being tested. So we use this table just to understand about the scale of the test. So the domains here around, understanding your current situation. So what's your confidence that the change idea that you're testing will lead to an improvement? Is it high or is it low? And what's the cost of failure if it goes wrong? So they're two really important things about the thing you're testing. And then on the other hand, you've got what's the staff readiness to make change? How bought into this are people of making the change happen? So if you've got a high degree of belief that the thing you want to test out, that you've got a hypothesis about, it's going to improve things, the cost of failure is really small and everyone's really bought into it, you're probably pretty much ready to implement a change in your system. If you're not really sure about what's going to happen if you test this change out, things might go quite wrong for you or the team if it goes wrong, and everyone's a bit ambivalent. I would suggest that you really need to be going for a very, very small scale test of change. So that might be, for example, if you were trying out a new script for answering the telephone, you might try it out on 4 or 5 phone calls. So you're doing a test that's really rapid cycle of testing and learning in a few minutes, rather than kind of implementing a new system and then you've got to live with forever. So I would really commend this to people if you're thinking about doing some testing, because what it enables you to do if you're using it well is get to testing stuff really quickly, testing and learning. And that's the whole point of PDSAs, and the slide that Anna referred to before about this, you're trying to move away from spending months of planning and then implementing something and experiencing the any untoward effects from the thing you're testing out, but actually thinking, how do you get to testing really quickly so that you do cycles of testing and learning, and you understand things and you build that degree of belief, and then you're ready to implement once you've tested it out in lots of different ways. So always think about these 3 things. What's your degree of belief? What's the cost of failure? And what's the staff readiness to make the change? Next slide, please. So this illustrates the approach that you can take then. So we're looking at rapid cycles of testing and learning. And I always think about this almost like a snooker player would be planning shots ahead. So, you pop one ball, you're going to plan for where the thing lands for the next shot you're going to play. So with a sort of a ramp for improvement, you test it, you're taking things from hunches, theories, ideas, and then you're testing them on, maybe this is an example here, looking at whether patient assistants can support different patient groups with submitting an online consultation. So does that increase the proportion of online consultations received by the practice? So you actually, the first PDSA is testing a consultation template and a script on 1 patient who doesn't speak English. Next, you take your learning from that and you adapt it slightly, and then you test it on the next 5 patients who don't speak English. Great, so you've learned a lot more then through that process. Next thing, you might try it on a different patient group. So you may be trying it on some elderly patients, and then you do your learning from that. Then you continue to refine your script and your templates, and you test it and you keep on testing. So that by the time you get to implement something, you've tried it out in lots of different ways. You've learned a lot of the things that don't work about it, and you've started to adapt the process to mitigate against those things. And so by the time you're looking to implement something, you've got a really good degree of belief that this thing's going to work. And what we say at the result of every PDSA cycle, the 3 A's come into play. So you either adopt the change that you've tested, you adapt it, so you improve it based on what you've learned through that last round of testing, or you abandon it. And one of the great things you want to learn about PDSAs is just to test something and let it go if it doesn't work, because the cost of failure is lower when you're testing small rather than implementing, when the cost of failure can be quite large, both in terms of an ineffective process or staff morale or even safety. So go on to the next slide, please. So next we're going to go on to measures for change. So if we move on to the next slide. And so when we're looking at access, what to measure is really important, and I like to break it up into 2 separate halves here. So you're looking at the technical elements of access. So that's the kind of nuts and bolts of numbers of appointments, number of telephone contacts, the mode of contacts that you're making, the rate of calls coming through to reception. which job role is doing the consulting, what's the conversion rate from an online consultation through to a face-to-face consultation, for example. What's your failure rate? So who doesn't turn up to appointments? What's your failed encounter rate? How many people drop off the phone before they get their call answered? These things are all very much the kind of technical things that you can look at to understand the effectiveness of your access. And you also want to look at who is accessing services and probably possibly more importantly who isn't, and that's particularly true around things like online and digital. So we wanted to be aware of the patients we're seeing, but also the ones that we're maybe not seeing who should be. And then on the other side, you have this idea that access is actually a sort of perceived or an experienced thing. So what's really important there is how does it feel to operate a system of access? So what's the staff experience or the team experience of delivering access? And then equally important, what's your patient and carer experience in terms of actually trying to make the appointment, getting the mode of contact that people actually want from when they make contact. And was the time that they had their contact convenient for them? Was it when they needed it? Was it the right mode? And what was the overall experience? And did you leave that encounter in a better position to manage your own health? All of these things are really important, and they're kind of almost like the environmental issues and the perceived issues around access. Next slide, please. So we're going to focus in now on the perceived side of things. So what's mentioned in the guide, and this is an extract from the guide here, are all the different places you can get that patient experience metrics and information, both qualitative and quantitative, about how it feels to access your service. So the ones I'll zone in on most are GP patient survey and local sort of local patient group reports. But you can see there's the Friends and Family Test, which has been suspended and is going to be replaced by another real-time experience or near real-time experience measure of accessing care. So that's coming probably in the next 6 months to a year, and it's being tested at the moment. We all know about NHS Choices and NHS UK, and one of the things we would always say to teams is be on top of that, because all information that you're getting, whether it's a 1-star review or a 5-star review, is telling you something. It's all data, and if we kind of take I don't know, we all know kind of reading a bad review hurts us as a team, and I think we want to make sure that we take the emotion out of that and get the information out of it. So we always really advise teams that you want to respond to all reviews, positive and negative. It's really important to share positive reviews back with your team, because not every team member always looks at NHS Choices, but it's great when you get some positive feedback coming in. Great to flash that up to the team and make sure we're all feeling the benefits of positive reviews, but also we're getting the information and the data out of the negative reviews, because they're all telling us something about things that can be improved. And for most people who operate appointment systems, frontline teams, administrative teams, patient assistants, they're the sort of intermediary between often a system that doesn't work very well and people who are trying to use it. So they're in a really difficult position. And if you improve the system, you will improve things both for the people operating the appointment system or the access system and those trying to use it. So we'll just have a look at the GP patient survey and I think how to get the best out of that. So if you pop onto the next slide, there are a couple of contractual things. So from in the GP contract 2021-22 and then moving into 22-23, there's going to be a real focus on making sure that practices are looking at their GP patient survey and acting upon it, and into 22-23 doing the same on the near real-time survey that's coming through to replace Friends and Family. So I think this really states clearly that the patient experience of access and the citizen experience of access is being taken much more seriously from a contractual point of view, and I think that's really positive for everybody. Next slide. Thank you. So this is just an extract from this year's GP patient survey. So it has its faults, and we know that it doesn't necessarily always. There are issues particularly around some patient demographics that answer the survey, but we can't dispute the fact that it's answered by a lot of people. I think that really says a lot about how much people care about their GP services and their local GPs. So 850,000 responses to GP patient survey. And the news is that that 83% of people, despite all of the challenges that we've been having through COVID and access and the headlines and all this sort of business, people are experiencing overall a good experience of access of their GP surgery, and that's improved from the year before, from 2020. So that's even through COVID, people's experience has improved. 96% of people, so that's and up from 95%, say that they have trust and confidence in the healthcare profession they saw, which is incredible. And I think that, you know, we've got to take this and be really very, very proud of that as a profession. And then 94% of people say that their needs are met at their last appointment. So I think, you know, I really want to hone in on those results, because, you know, I think it can feel pretty bleak at the moment, and we're certainly in the firing line in terms of the media, and I don't know many other professions that could show data like this and show consistent improvements as well. Next slide, please. I think though one of the things when we're looking at GP patient survey, and I really commend you to go and kind of check out your practice network CCG results, just to know what is a significant change for you as a practice, because I think sometimes you can look at the results and sort of not really know whether anything's happening or not with them. And just to let you know that, so a change of 0.1% at national level is statistically significant. So that move from 94 to 95% in terms of satisfaction is a statistically significant increase in satisfaction with GP services. For your average CCG, a change of just over 1% is significant. But for an average practice, and I've kind of said, you know, I don't know, that's got 8 to 10,000 patients, should we say, you actually need a change of about 6%, or just over 6%, to say whether something has either improved or got worse, as in your GP survey results. So I think that's just important to note, so you could understand almost like where to react when you're looking at your own practice data. What we'd also say is that the GP patient survey is broken down into a number of different domains. So this, and the ones that for me are helpful around access particularly are the one around your last appointment, number 5, which is overall experience, and number 6, which is making an appointment. Although what we've started to do when we're working with practice teams is to look at differences across multiple domains, because we sort of think if a practice has gone up across multiple domains, that's something to be interested in, but also practice that is dropping not just in one area but over a number of areas, that certainly for us warrants a bit of a closer look to see what's happening. So we've got some data here just up on the top right, which we're looking at practices on my patch around the numbers of practices that have sort of shifted upwards in positive responses in multiple domains, and practices that have shifted downwards across multiple domains. And I think that these things are, you know, again, whenever we're looking at data, it's, you know, what's the signal and what's the noise, and I think a significant changes, particularly in multiple domains, you know, is definitely something where a practice or a network would want to be taking a closer look. Next slide, please. And just the last bit from me, one of the resources that we use an absolute load around my neck of the woods is Healthwatch Data. So you'll know from GP patient survey data, obviously the survey is very flat. It's sent out, you know, in one time period per year, and it involves people who've accessed and not accessed services. When we wanted to have a bit of a deep dive into practices, we use on our patch the Healthwatch Community Insights data set, which will, and our local Healthwatch scrapes all of the data that's available around local services. That will be anything from Google reviews to NHS choices to GP patient survey, friends and family when that was around. They also do interviews and really deep insight work around, you know, very specific areas. So they've done for us and with us recently loads of interesting stuff around digital inclusion, which has been such a rich resource for us when we're working with practices. But they're getting such a large quantity of data, both qualitative and quantitative, which we can then turn into lots of interesting insights for practices to sort of look at the, you know, the main drivers for positive experience for a practice, and the main areas where patients are experiencing a negative experience trying to access the services. So I would really sort of commend you to reach out to your local Healthwatch. You know, maybe you've got an area of interest that you want to explore in a bit more detail. Maybe there's a really good existing data set out there already that you can use to identify an improvement project or an area that of particular strength in your practices that you might want to base your next project on. But I think it's just helpful to look wherever you can for this kind of information, because we think if you can pick out the right topics, these are things that are going to both help people experiencing your services, but as a direct result will make your place of work a better place to be. Thanks, Sean.
Thank you, Tom. That was really good. Anna, if we could ask you to turn on your camera again now. And then I think David, who's been helpfully behind the scenes collecting questions, and I know we had some questions that came in before the webinar. So David, I don't know if you're happy to fire them at us, and we can see, we tend to get stuck on one question and then end up talking about it on the previous webinars, but let's see how we do today.
No problem. There were a number of questions that were raised as part of the registration process. The first one has been covered by previous webinars, but I think perhaps it's useful to pick up again for this one in case others haven't had a chance to view those. And I suppose it's a general question around how do we find the space, the headspace and the time to be able to put in place these QI practices, given all the capacity issues that we're experiencing at the moment?
Oh, I don't know. I'll kick it off on that one, and then I might. Oh, Tom, you're ready to. I'll let Tom go first. It's a hot potato. I'll let you go first.
I think for me, it's the stop before we start thing. What's been done already, but I really commend this thing about scale of test. I mean, I think it can feel like everything we need to do needs to be some kind of gigantic project, whereas actually, the people closest to the task often are the people with the most ideas about how to make it better. And if people have got the autonomy and permission and the authority to make changes as rapidly and test them out, I think that you're creating that space for improvement and engagement in the team, and you create that energy because people are sort of testing and learning all the time. My colleague George Farrelly, who's my sensei of all things improvement, he always says, you've got two jobs: do your job and do your job better. And I think that's a really lovely attitude to take into these things. But if it's all feeling too much and there's no time, that's because you've probably taken on something too big. Like, break it down. What's the smallest way you can test and learn to make this thing better?
Thank you, Tom. I think I'd add to that and sort of build on that, this idea of the person closest to the task. I think quite often in general practice, and we talked about this in the team section, we often have quite a kind of hierarchy where everything sits with a few people at the top, and that overburdens the people at the top, and they just don't have time, capacity, and it feels overwhelming for them, and it disempowers other people in the team. And so I think it's really recognizing the skills of the people in your team and allowing them to try some small things, and also allowing them to make mistakes. I think we're really bad in healthcare about thinking everything has to be right first time. We will need to go down some blind alleys, and we need to create that culture that we talked about in the team section, which is kind of forgiving of ourselves and forgiving of our colleagues, because it's only through that we kind of develop that sort of trust. So don't hold it with just a couple of people. Make sure that you're using your full team, because they'll have some great ideas, and your patients will have some great ideas. Anna, you're nodding. Have you got some thoughts on this one?
I get asked a lot of the time where to make a start with QI when you're way too busy. And what I've learned over the years is just look at what you're doing now, particularly meetings and things where you're coming together as a team, and see if you can make those more efficient. There's some very simple tools out there, like on the Sheffield Flow Coaching Academy, for instance. They've got a one-page template on how to run really effective meetings, and quite often if you can make those kind of things more effective, it's surprising, you can suddenly get 20 minutes in your day that you weren't expecting. Now, I know that sounds simplistic, but actually it's looking at the things that you could stop doing that will help you to release a little bit of time to squeeze this in. And sometimes it is a squeeze, we just have to admit it is.
And I guess it's back to that 20/80 as well. Are the meetings that you're having, are they dealing with the 20% that really makes a difference? And I think sometimes external pressures and things which are put upon us from external are often not in that 20%. And so sometimes we have to be a bit kind of brave and a bit ruthless about tick boxing in some areas and actually really doing some deep work in the areas that we care about and our team cares about. But there's no easy answers to this. If it were easy to lose weight, we'd all be wandering around with a BMI of 21. If it was easy to offer good access, no one would have any negative complaints on their NHS choices website or whatever. So it's not easy, but there are some simple things that you can do to start you on the right pathway. So, and I think there is some sort of cross-learning in that, isn't it? How do we speak to our patients about making changes in their lifestyle? And actually, there's probably some overlap. Okay, David, I think we've done that one. What else have you got for us?
There was a kind of linked question around what QI product would you recommend? And I appreciate we've just mentioned that it depends on what practice and also the access systems that they're struggling with. But I think, Tom, you've mentioned in the past that there's ways that you can look at DNA rates if the practice is struggling with those. I suppose, are there one sort of key focus areas that you could think of? Because given how broad the access spectrum is and how many different QI projects you could, in theory, look to.
I tend to sort of think about, do you just know where you're at the moment? I think it's quite hard to make an improvement in a system you've not kind of understood yet. And I think just do you know how many appointments you're offering, how many contacts you're offering, by what mode, who's doing them, does the time taken equal the time allotted? All of these are really basic questions. I think for me they're kind of foundation elements, and then you can start to do lots of interesting stuff. But what we would often do with the team is just like, well, let's just map the process from somebody expressing a need to that need being met. And what you'll often, if you can get, particularly if you get service users and patients in the room as well as your team, you'll find so many opportunities for development and improvement just within that that core piece of work that we do. So that's would be the tried and tested method for us, really. Map the process, what's happening, how well does it work, which steps add value to you, which steps add value to the people trying to use the service, what are the numbers attached to each of these things, how much happens here, how many don't reach here, how many convert to that step, what about this, and then you're getting those great conversations happening.
Anna,
Yeah,
have you got any thoughts on that one?
I'm just nodding away to Tom. I'm loving what Tom is saying, and I think what I would say is I always hit the data. I always look at what's the data telling you in your GP practice. Where's it telling you you've got your bottlenecks? Where's it telling you that you've got your issues? And then, when you look at that, if you're starting this for the very first time, don't go for the trickiest one first. Pick one that you think you're most willing to go for and that you've got the right energy for, and try that one first. And see how you get on, because in a way, the first time you're doing any quality improvement, you're also doing PDSA cycles on how to do improvement as a team. So you're trying to get better and better at that as a team and a group process, alongside trying to make an effective change. So yeah, start with something where you think you might have a chance of making some simple improvements quite quickly.
Yeah, I'm just going to add a few bits onto that. One, plug for the guide. Sit down with your team, have a look at the guide. It's got this idea of the whole system. There will be bits that you're doing really well and you should pat yourself on the back for, and kind of go, actually, we've got a lot of this in place. Actually, where are our weaker points? Two, I think one of the things I've learned from the work that Tom and the Equip team have done is actually sometimes coming together beyond your own practice is needed, because actually you do need a bit of time and thought to look at the data sometimes, or collect the data. So think about how you use your PCN development funding, or if there are any commissioners on the line here, think about how you can work collectively across a borough area, perhaps to support a quality improvement programme for access. And then I am going to give a suggestion of a single project if people are interested. So in the guide, we've done some we've quoted the work by Rebecca Molby from London South Bank University, who looked at people who attend very, very frequently. And we have a very small number, and I think most practices will have this, a very small number of people who come very, very often. And they don't just come to us very often, they're often using multiple services very often. And they're coming very often because we're not meeting their needs, and they need a different type of approach. And we've got new people coming on the teams. We've got social prescribing link workers. We've got health sign, but we've got lots and lots of new resources. And actually, that's a really nice project to start with. Just thinking about who are your patients who consult maybe more than 30 or 40 times a year, and thinking about a kind of individual approach to them. So that would be a suggestion if you're sort of thrashing around looking for somewhere, and you can do that as an individual practice. Okay, David, what else have you got for us?
There's a few broad questions, and one was focusing on how could they improve patient engagement. And I know that's been covered as part of the sort of webinar for the last webinar, but I wondered if there's any quick questions or quick points you can give about tips about how to improve engagement with patients, especially around improving access systems.
Should we start with Anna on this one and then go to Tom?
I think what I've learned over the years about improving patient engagement is think about the places that the public come to in your environment. So think about your waiting rooms, think about the actual physical building, and also increasingly the virtual space. So think about how you can engage people with some of the issues that you want to get their thoughts on, and think about simple techniques that you can invite feedback and you can ask people to get involved with improvement ideas. So sometimes simple is really good, you know, putting up a poster and asking people kind of, what are your thoughts on this? We think it's a bit of an issue. What are your ideas? Some of this is low tech stuff, but really, really effective for getting people involved. And I've always been surprised when, you know, then if you ask at the bottom, would you like to get further involved, or would you like to, you know, join a focus group to help us think about this a bit more? It's really surprising how quickly you can get patient engagement from things like that.
Thanks, Anna. Tom, some thoughts?
I think I went really super high tech, and I ran a tea trolley trial pre-COVID. I just kind of got the tea trolley, got some fruit snacks and some biscuits. Don't tell anybody, but I got, you know, tea and some juice water, and just wandered around the waiting room and just picked people off to see whether they, you know, just to kind of get a sense of how they were finding things in the practice. And it was a fantastic experience. I did get kind of mobbed for requests for various bits and bobs, but even that was really interesting, because it's like, okay, there's so much work that's coming into the practice that just actually requires a bit of troubleshooting and signposting, and should never really make it past a particular point. But I probably got more information and data and ideas from you know, a couple of hours and some tea bags and some hot water than almost anything else I've done. And people were really up for kind of, you know, getting involved and sort of giving you opinions, advice, and also engaging in future work. But I think there's something I was saying, you know, it's one thing to ask, it's the net, you've got to close that loop. It's people, you know, if you've asked what you think and then somebody doesn't do anything about it or acknowledge it, then you're probably going to be a bit more reluctant to give that, you know, give your time up again. Whereas, I don't know, I really sense that people are very engaged with wanting to kind of help sustain a local resource. I think, you know, all the data would suggest people value this enormously, and I think that we can really engage with that. But you also have to be, I guess, ready to hear some things that are difficult, as well as things that you want to hear. But that's part of the learning experience, I think.
I really agree with that. I think one of the things we've learned in Northumbria about patient engagement is transparency around the data. So putting our data up on the walls, if you walk into any of our hospitals, you'll see how patients rate our doctors. You know, it's been open to saying, we know we're not perfect. We want your ideas about how to improve. And it's almost thinking of patients and carers as this incredible improvement kind of workforce alongside you, because people can spot the issues and they can give you amazing feedback and give you fantastic improvement ideas. So it's thinking more generally that we're all in this together, really. And
also, and I was thinking we did something similar about digital engagement. Yeah. We did it with a group. We did a sort of data wall, got some people in, and a guy was like, "Yeah, you're not really doing this very well. I work in digital marketing. This is my job. Let me help you." And it's like, oh my goodness. So it's not even
exactly.
You know, this is like, this person knows so much more than we do.
Yeah,
implementing digital, and it's like, great, come on. And he was like, right, just tell me where I need to go. What do you need me to know? What do you need to know? It was like, oh my god, it completely changed the sort of, you know, the kind of the power and the dynamic of the whole experience. It's fantastic.
Absolutely. I don't think, you know, I think that lived experience, it is just such a strength, you know, and the learning is so rich and deep that I think once you start to do deep co-production around these kind of improvement ideas, you never go back, because the benefit is so great.
And there are ways of doing this as well, aren't there? I mean, if you can do it in the physical space and in the current climate, so maybe around a flu clinic or when people are physically coming in, you need to grab those opportunities now, because we don't have as many as we used to. But there is also the virtual space, and we've talked in the working with patients about the importance of a good website. You know, and if you have a really, you know, and you can have a "you said we did" poster in your waiting room, or you can have a "you said link on your website. There are ways of doing it both in the virtual space and the physical space, and I think it's thinking imaginatively and being brave enough to ask and being a bit honest. And I think that does break down the natural hierarchy. We talked about a hierarchy within our teams, but we've often got an even greater hierarchy between the doctor and the patient. And so it's really kind of thinking about how to break that down. And I like your idea, Anna, about the transparency and honesty of that. Now we've come to 6 o'clock, so I think we will have to stop there because I'm sure everybody's had a long day. Have we got anything on the word cloud and is it a positive thing or is that a bit risky? Let's see if we can finish off with the word cloud. So we have got some really nice things. So the larger the wording, the more people who've said it. So yes, if we do have a success in an app, in an access project, we'll have better health outcomes. We'll have more satisfied patients. I guess happy is across the board, happy staff, balance, reduced DNAs, enthusiasm. Oh gosh, this is really good. I'm really glad that we've done that. We will capture this with the slides. And I think the slides, David, are they going onto the website as well?
We will look to put them all from each of the 5 webinars as well onto the website.
Okay, so on the website, the links in the chat will be the recording of the webinars. So please encourage your friends to look. Please do use the guide and manual, and please have a look at this lovely word cloud. Actually, today's work done today: better patient experience, fulfillment, able to cope, flexibility. Oh wow, that's really, really positive and lovely. So thank you all for joining us. We're 1 minute over time. If I could ask the speakers to stay on just for a few minutes. And Adam Jenkins, thank you so much for that lovely little comment.
Thank you, Adam. Thank you, everybody.
Thanks,
Good luck with it all.
Yeah, good luck. Thank you.
Well, very much.